Hello, welcome patients, caregivers, advocates, and guests. And I want to thank you all for joining us at the Together Facing Colorectal Cancer session tonight. I'm Dr. Crystal Denlinger. I'm the chief of the Gastrointestinal Medical Oncology Program. I'm the director of the survivorship program and work in phase 1. And I am very excited to be joined today by a number of my colleagues across the spectrum. And I'm really looking forward to talking with them and with you all about the latest research and treatment developments for colorectal cancer. Although we'd prefer to host this event in person and wish we could all be at the center this year with each of you, we hope that you find this program to be really helpful and informative from the comfort of your home and leave feeling inspired to go forward and continue to advocate for colorectal cancer patients and survivors. At our Together Facing events, we traditionally begin with a moment of silence to honor those we've lost to cancer. And so tonight, before we get started, I ask that we pause to remember them and their memory. Thank you. I'd also like to take a moment to thank our exhibitors this evening. It's because of their generous support that we can offer this program to you free of charge tonight. Special thanks to our gold exhibitors, which include Bristol Myers Squibb, Genentech, Guardant, Natera, Oncosec, Tempest, and Urigen, and our silver exhibitor, Lilly Oncology. Also, thank you to the following advocacy organizations for their ongoing support and partnership: the Colon Cancer Coalition and the Colorectal Cancer Alliance. As many of you know, colorectal cancer was a top news story a few weeks ago after the untimely passing of 43-year-old actor Chadwick Boseman, who'd had colon cancer. It's really sad to see that it takes a well-known name to succumb to this disease to really raise awareness. But if anything good comes from this, it's that for young people, especially those in the African-American community, to be thinking about colorectal cancer, to know the symptoms and to get screened, especially as there are changes in the screening recommendations over the last few years. Lack of awareness, of course, is one of the major reasons that colorectal cancer is not usually detected in younger adults until the disease has advanced to later stages, where survival rates are much lower. And we hope that the experience and the awareness that comes with Mr. Boseman's passing will actually encourage people to think about colorectal cancer and screening and to understand and know some of the signs and symptoms of colorectal cancer. So I'm going to start tonight by introducing the panel. Each of our experts tonight has been chosen specifically for their expertise in colorectal cancer and will give sort of a 5-minute talk about a particular area of their interest. So what I'm going to do is actually introduce each individual panel member and ask them to talk a little bit about their particular interest, and then we'll go and introduce the next panel member. But just quickly, we have tonight with us Dr. Michael Hall, who's the chair of clinical genetics and a medical oncologist. We've got Dr. Rishi Jain, who's an assistant professor in medical oncology and a GI med onc. We have Dr. Jeffrey Pharma, who's our surgical oncology representative. Dr. Josh Meyer, who is the head of the radiation oncology program, and Pamela Jakubik, who is our ostomy nurse. So I'm going to start with Dr. Hall. He is the chair of the clinical genetics program. He runs our high-risk program and also very active in the GI medical oncology program. So Dr. Hall, I'd really like for you to talk to us tonight a little bit about what's new in genetic risk assessment and also some of the new updates in metastatic disease.
Sure, it's my pleasure. Thanks for having me. I think this is a great event. I'm so glad we had such a huge turnout too. I think that's super exciting. So 5 minutes is not a lot of time in these areas, but I thought I'd try to sort of encapsulate a few of the exciting things that have happened in the field in metastatic colon cancer and in genetics. So in metastatic colon cancer, I narrowed these down to sort of 3 changes that have occurred in the field that have kind of pushed the envelope a little farther and identified 3 more sort of exciting targeted areas that are now available for us to treat as medical oncologists. So the first is related to a trial that was reported this year at our big national meeting that looked at a specific subgroup of people with metastatic colon cancer who have something called MSI high colon cancer or microsatellite high cancer. Now, this is only about 5% of people with metastatic colon cancer, but I think what you'll learn by the end of what I'm saying is that once we start to add up all these small pieces of pie, we're slowly getting a much larger piece of the pie over time. But so this was the first small piece of pie, 5% of people with this MSI high. And what this study showed is that in the group of people who are MSI high, we can now use immunotherapy, not just in the advanced disease setting after we've used chemotherapy in a number, sometimes 2 or 3 different lines of therapy, but actually in certain patients, even in the upfront setting, we can use an immunotherapy to treat these patients. And I've actually been fortunate to have a couple patients I've been able to do this in. What they found in this study is that the risk of progression in people who got this immunotherapy, the risk of their disease progressing and needing a new therapy was reduced by 40% in the people who got the immunotherapy, which was a huge advantage over chemotherapy. They also showed that the duration of time that the immunotherapy worked in the people for whom it responded, that the duration of therapy was, or the duration of response was so long that in the amount of time that the study has been open, they haven't actually been able to measure that median amount of duration. So that tells you that is an incredibly amount of time. Now, in the chemotherapy arm, the median duration of response was about 11 months, which is pretty typical for what we see. So the fact that it was so long that it's beyond what we're even able to measure with the trial right now, again, was super exciting. And the last sort of little tidbit I'll tell you about this study was that at the time that this trial stopped collecting data, at 2 years after it started, 83% of the people who were responding to the immunotherapy continued to be responding to the therapy. Again, telling us that we've definitely hit on something big with immunotherapy. Those people who are eligible, again, this 5%, and those who respond can actually sometimes have durations of response that are far beyond what we've seen in chemo. So, of course, now the burden to us as doctors is to try to find more targets like MSI, and, of course, we're working on that. The second thing I wanted to tell you about was another study that came out called the Beacon study. So this study addressed actually a particularly difficult group of people to treat, a group of people who have a mutation in their tumor that's called BRAF V600E. This is a mutation that, again, is only about 5% of patients, but in this case, it's sort of a bad thing. People who have this, it is a particularly challenging group of people to treat. The tumors are often much more resistant to standard chemotherapy, but what a group down at MD Anderson and of course others who participated in this trial were able to show is by using a 2-drug targeted therapy, they were able to extend the survival time in patients who have this very difficult to treat mutation by about 55% over what you saw if you just used standard chemotherapy. So again, that is a huge increase in the amount of survival time in this group of people, because it was, for us, always, again, one of the hardest groups to treat. So I think that was an incredible leap forward for us in colon cancer. That those changes, that trial immediately made it into the national guidelines, and I think probably almost everyone on the call has treated someone with these new targeted therapies. So that, again, for another 6% of people, is a great advance. Finally, I'll talk about one other target. HER2 is a target on colon cancer that actually we've known about in breast cancer for a long time. In metastatic colon cancer, we know about, again, the magic number, 5% or so of metastatic colon cancers will have this marker. But again, what we were able to show, and what has now entered the national guidelines, is we can use a number of targeted therapies that have been used in breast cancer, also in esophagus and gastric cancer for a few years, but now they've entered the guidelines and we can use them to treat that small group of patients with colon cancer who have that marker. And so if you add the MSI plus what we've learned about BRAF plus this HER2, now we've hit about 15% or so of colon cancers. And again, all of this has come along in really just the last few years. And I think that's super exciting for patients who are having to deal with this disease. So let me then flip over. I'll use my last one minute or so to talk about genetic risk. So I think the two big things in the gene world that have been really big advancements and have really helped my practice in terms of my ability to test people and make recommendations, that is that Ohio State University published a big study where they tested about 500 people with colorectal cancer diagnosed under the age of 50. And what they showed was that the rate of mutations in those people, mutations that were inherited through the family, that we have targeted therapies potentially to treat and that are relevant to healthcare, the rate was about 15%, which was, I think, much higher than anyone had anticipated before. Now, they're doing a follow-up study to also look at patients over the age of 50. I think a priori, a lot of us are guessing that the rate is going to come in at probably about 7 to 8%. So I think, like what we've seen in ovarian cancer and pancreas cancer and prostate, we may see in the next year or two, hopefully, universal colorectal cancer testing, which I think would be amazing. The last point I want to make is that the group from Memorial Sloan Kettering and from University of Michigan had two very nice studies at our national meeting this year where they looked at hereditary risk mutations in patients undergoing tumor testing. And again, another magic number, what they found was roughly about 13 to 15% of patients who have tumor testing, and this included patients with colon cancer, ultimately have a germline mutation that they've inherited through the family. That is an extraordinarily, I think, profound and high number. And I think what it basically says is that with a few exceptions, most patients who have cancer, probably their doctors should be thinking about sending them to a group like mine to think about whether genetic testing is relevant. So I think these were very exciting data. They've shown that hereditary risk is incredibly relevant to the treatment of cancer, and I think will definitely lead to changes in the national guidelines in the years to come.
Thank you. So yeah, I think right now this has been an amazing time to be in colorectal cancer because we're learning all sorts of new things about small subpopulations. And I think we're getting more and more targeted therapies to hit these populations, and it's changing the landscape for these populations. So thank you very much for that great summary. So now I'm going to turn to Dr. Rishi Jain. He's an assistant professor in the Department of Hematology Oncology here at Fox Chase Cancer Center and also directs our nutrition program. And I'm going to ask him to talk a little bit about updates in adjuvant therapy, because there have been some updates in the adjuvant setting, just like in the metastatic setting, and then also talk a little bit about nutrition and cancer and how that applies to patients with colorectal cancer. Rishi.
Great. Thanks, Crystal. So to just quickly define what adjuvant means, it's chemotherapy given as part of the curative intent therapy. And for colon cancer and rectal cancer, a big proportion of patients do require some chemotherapy as part of the curative intent approach. There have been some advances in the adjuvant chemotherapy regimens that we use. In particular, there was a big study published called the IDEA collaboration study. And this was a large randomized international trial accruing over 10,000 patients, where they randomized patients with stage 3 colon cancer to get either 3 months of chemotherapy or 6 months of chemotherapy. And what this study found is that 3 months of chemotherapy was almost as good as 6 months of chemotherapy. And in a big proportion of patients, now we can offer 3 months of therapy instead of 6 months of therapy. There are some details that need to be taken into consideration in collaboration with your oncologist to see if you are indeed eligible for 3 versus 6 months. But the benefits of 3 months is less side effects, in particular less neuropathy, which happens from one of the drugs included in the chemotherapy regimen, oxaliplatin. So that's a big advance in the adjuvant chemotherapy space. Another advancement which is up and coming is there are some other tools being used to help us tailor our chemotherapy better. There is a score called the immunoscore, which is a tool that has shown that it might predict which patients are more likely to benefit from chemotherapy. It's not approved for use yet, so it's not something that is considered standard of care, but definitely stay tuned because it seems promising. And there are also blood tests that might be better than the CEA level that we commonly check. There are technologies being developed looking at circulating tumor cells or circulating tumor DNA, and those might be better ways to follow patients after they've completed their treatment, or even help in the decision making in terms of who will benefit most from therapy. But again, these are not considered standard of care yet, but you should definitely stay tuned because they, again, seem very promising. Just to switch gears to another area of interest of mine in the area of diet, nutrition, physical activity, and colorectal cancer prevention. There are increasing data that lifestyle factors can modify your risk for colorectal cancer. The leading organization that summarizes this evidence is AICR, the American Institute for Cancer Research, and they published guidelines recently that gave pretty strong evidence to certain factors that can both increase or decrease your risk for colorectal cancer. So things that they said showed strong evidence to decrease colon cancer include physical activity, eating whole grains, eating foods with fiber, and it also showed that dairy was beneficial. In terms of things that can increase your risk for colorectal cancer, they did find that excessive consumption of processed meats and red meats can increase your risk. Alcohol and being overweight or obese also can increase your risk. So there are things that you can do to modify your risk from a lifestyle perspective. In fact, they estimated that almost 50% of colorectal cancers could potentially be prevented with a healthy lifestyle, which is a huge proportion of colorectal cancer. So definitely an area where we have to do a better job in terms of educating our patients, but those are some, exciting areas in the colorectal cancer space right now.
Great, Ruchi. I'm sure there'll be some additional questions from the audience about ways to prevent recurrence or address diet and exercise and lifestyle. So we'll come back to you here. But now I'm going to turn to Dr. Josh Meyer. So Dr. Meyer is the Vice Chair of Translational Research and the Chief of the GI Radiation Oncology program, and he is our main radiation oncologist. And Josh, I'm going to ask you to talk about what's new in radiation therapy at rectal cancer. There's been some new updates and some paradigm shifting thinking right now. And so do you want to give us a few minutes of what's going on in the world of radiation?
Yeah, I'm happy to. It's really my pleasure to be here, and I'm really glad that we're able to do this event virtually. And I think that a lot of people are able to participate, maybe even more than could come to Fox Chase on a Wednesday night. So this is really terrific. So there have been a few studies recently that are really causing us to think hard about how we treat rectal cancer in particular. So when it comes to radiation, we care a lot about exactly what part of the body we're treating. Unlike medical oncology, chemotherapy goes everywhere, but radiation is focused in a particular spot. And rectal cancer is very different to me than colon cancer. So I'll talk a little bit about rectal cancer. We have seen 3 big studies with early results that are pretty exciting and causing us to think a lot about what's going on. So the standard treatment for rectal cancer is chemotherapy and radiation, which is given for about 5 weeks. And after a recuperation period of somewhere around 2 months, patients then go on to surgery and then typically get chemotherapy after that. The first study actually compared that standard treatment to a short course of radiation, so 5 treatments over a week, followed by chemotherapy and then surgery at the end. And what they found with that smaller number of radiation treatments and moving the chemotherapy up was that they could improve some of the outcome measures in terms of the response rate of the rectal cancer significantly, pretty much doubling the percentage of patients who are able to have a complete response to the radiation and chemotherapy as compared to the standard treatment. And this seems to be pretty effective and may be something that we can consider in a lot of patients where the standard treatment may not be what they need. It's very complicated to decide who gets which treatment, and I'm going to refrain from trying to identify specific patients for whom one treatment is more valuable, but this is a great option to limit the number of radiation treatments and get to the chemotherapy sooner, which is, I think, a big deal. It can help us prevent disease from spreading and treat the rectal cancer aggressively. So that was the first study. The second study was a real intensification of treatment. So this was a study where they took the chemotherapy that we typically give after surgery and gave it first, but they also added a third drug to the chemo that we usually give. So this is, instead of a combination called Folfox, which is 2 drugs, this is FOLFIRINOX, which is adding a third drug, irinotecan, to that regimen. So they gave that for several months and then went on to standard chemo and radiation for about 5 weeks after that. In that study, they had very high response rates as well. So patients went to surgery, seemed to be doing quite well. And these were patients who had fairly aggressive tumors, and it's pretty impressive to see that these patients seem to tolerate this aggressive treatment pretty well and seem to respond better than patients who got the standard therapy. So that's a second option. And then the third option is patients who had either chemo and radiation standardly, followed by chemotherapy, or chemotherapy for several months, followed by chemo and radiation. And then this study was attempting to have patients followed and not operated on if they had a complete response clinically, and just watch these patients either with a sigmoidoscopy or an MRI, or actually with both, and confirm that they didn't need surgery and they didn't develop any additional disease. And the results are early, but it seems to show that at least in the chemo and radiation followed by chemotherapy arm, that up to 59% of patients were able to avoid surgery. Now, again, we want to make sure these results are mature, meaning we have long follow-up so that we can confirm that patients don't do well for a few years and then start to recur. We need to think very carefully about which patients are best for which options, or said the other way, which options are best for which patients. But it is great to have options because for many years we have not had any options for patients with rectal cancer. So I think it's nice to be in this position where we now can have very detailed discussions with our patients, trying to match the best treatment for each patient's disease and each patient's life. And so I think I'll stop there. There's a lot of other exciting stuff that we could talk about, but I'm about out of time. So thank you for including me, and I think we'll move on.
All right, well, if we have time to get back to some of those other exciting things, we will. But now I'm going to turn to Dr. Jeffrey Pharma, who's our Chief of the Division of General Surgery in the Department of Surgical Oncology and a strong advocate for rectal cancer survivors, works closely with our advocacy organizations. And he is going to talk to us a little bit about updates in surgery and what's really new for colorectal patients and survivors with respect to surgery.
Thank you all. So it's great to be part of this event. I think these, events, and I know being virtual, but if we can impact more people, I think, that's a great thing. And I just want to thank everyone else who is on here, the other speakers. I think one thing about Fox Chase, and I think most of the patients that are treated with us know that really it's a team approach to treating the patients. And everyone on this call, I consider my friends and family, and we really work together on a daily basis to treat patients. And are discussing things after hours, via email, text, weekends, nights. And it's an absolute pleasure working with all these people. So thank you all for all you do. In terms of surgical techniques for colon and rectal cancer, I think things over the last 10 to 20 years have really changed dramatically. From the time when I was a resident or training, we've really shifted how we can manage a lot of patients and how we can operate on them. We've been able to minimize incisions, so we can use smaller incisions and minimally invasive surgery. or robotic surgery or local excisions. And all these things are really important for patients. But I think the most important thing is quality. We want to do, and I tell all my, I'm a cancer surgeon. The most important thing I can do is I want to do a safe operation, no matter what technique we do, that is effective at removing the cancer as safely as we know as possible. In the Department of Surgery at Fox Chase, we use all these different metrics and continuously evaluate and reevaluate these metrics to make sure that we're doing things safely, so we can limit infections after surgery, that we can limit hospitalizations, we can limit readmissions, all these things that if a patient needs subsequent therapy, we can get them on in a timely fashion and safely. And I think those are really, really important things with national efforts in terms of improving surgical outcomes that are really important. At Fox Chase, we participate in a national quality initiative called NCI-Designated, which is sponsored by the American College of Surgeons. So our data is actually compared to other institutions like ourselves to know that if there's areas that we're doing excellent in or areas that we can improve in. And so it's real-time feedback where we can actually change and institute initiatives that we can make surgery, and this is not just for colorectal cancer, but as safe as possible. If colon cancer or rectal cancer is found early, it is curable. It's a curable disease. So if a polyp is removed and has a small focus of cancer, you don't need surgery, it's cured. If we can go in and find an early colon cancer, most patients in that situation are cured. It's when patients present with advanced disease that then we have to do a lot more, and the treatment can be much longer. And so the number one thing, and we work with advocacy groups and have gotten funding to do research projects, but to increase screening nationally. It's really upsetting to know that, less than 60% of patients that should be screened are not screened in this country. It's especially when you're talking about something that's a curable and preventable disease. And so I think the number one thing that we can all take home is have your family and friends get a colonoscopy or screen for colon cancer. That's the number one thing we can all do. Because if it's identified early, it really just changes everything. It's when you're having significant symptoms or present with a bowel obstruction, and then we have to go in and do emergent surgery. And when emergent surgery is done, studies have shown that usually, outcomes are probably worse, that it's happening in the middle of the night. It may not be someone who is as familiar with dealing with some of these cancers or complex situations, and sometimes outcomes are worse. So moving on, so we do a lot of minimally invasive surgery at Fox Chase. Most upfront surgery, either of the colon surgeries or robotic or rectal cancer surgeries, are done using small incisions, robotically or minimally invasive. Most of the operations take us between 2 to 4 hours at this point in time. And we do some newer nuanced procedures and are pushing the limits. So we do know that if we can remove an area of cancer, even in the metastatic setting, including liver resections or lung resections, or even in select patients where it's spread to the lining of the abdominal cavity or peritoneum, we can do lung resections, liver resections. They can be done open or minimally invasive. We can do a procedure called HIPEC or hyperthermic intraperitoneal chemotherapy. So even in advanced patients, there's options. And when I was at the NCI, I think, where I did research, it really opened up my mind that there's always options. And I think you want to go somewhere where there is, we can say we have this as, the initial therapy, but there's other options from a surgical standpoint, a radiation standpoint, or chemotherapy standpoint. And that's what we offer our patients. As Dr. Meyer said, so there's many, many new options for rectal cancer patients. And if I don't have to do rectal resections, that would be wonderful. It's a much higher chance of requiring an ostomy or a temporary ileostomy. And if we could find the treatments that can shrink this disease, and where either I can do a local excision rather than a formal, life-changing operation, that's our goal. We're not there yet, but I think we've made a lot of progress. Where there are patients that we consider that have had a very, very good response to therapy, if it's chemotherapy or radiation or both, that, as Dr. Meyer said, we can watch and wait, where we just follow them closely. And if the cancer comes back, in general, we can do operations to remove it. I'm almost done. We consider sphincter preservation, and I think we really, really consider quality of life in all the patients that we see. We, with Dr. Jane, we're looking at, options for prehabilitation before you initiate therapy, if it's chemotherapy or surgery, where we can make you as strong, as fit as we can, that we know leads to better outcomes after surgery or any treatment that we offer. We have many clinical trials that we want patients to get involved in, so we can find the newest and best and kind of move the needle so we can improve how we take care of patients. So in summary, get screened, tell your family and friends, get colonoscopies. I want to do less surgery. We want to give less chemo, and we want to give less radiation. We really, really enjoy what we do, and take the team approach, but that's, the highlights of what I have to recommend. Thank you.
All right. Thank you very much, Jeff. I agree. I think if we could all give less things, it would be a wonderful world. And finally, I'm going to turn to Pam Jakubek. She is a clinical nurse specialist who works with us and with our ostomy patients. And she is going to talk to us a little bit about living with an ostomy, because that is one of the things that I think colorectal cancer patients worry the most about when they are presenting to have a discussion with Dr. Pharma, Dr. Meyer, myself, the medical oncology team. So Pam, you said something to me the other day when we were talking about becoming a survivor's friend for life, and I loved that idea. So if you could talk to us about living with an ostomy, I think that would be great.
Yeah, I think that is one of the biggest fears when somebody hears that they have colorectal cancer. A lot of patients don't have an ostomy, but some do. And my role here is to help those patients. I have a coworker. We're both full-time employed, and we're here for the patients preoperatively, postoperatively. And as I told you before, one patient came back 20 years later and said, well, I know that you're my friend for my life, so here I am. And patients might need help later on down the road. They initially, when they learn about it, it's something to learn. And they'll usually come back and say, this isn't hard to do. It's just a little harder to get used to. But it's not visible. The common misconception is that people smell, or it's a garbage bag hanging from their belly. It's very, very concealed. It's very manageable. People can still go, they can still have intimacy. They can still go and play in sports and other activities. Many times their diet shouldn't be restricted after they heal from their surgery. Depends on what type of ostomy. But we're here, and most patients have access to an ostomy nurse. But if they don't, if they had surgery here, or even if they're just here for their treatments and they didn't have surgery and they don't know about us, they can be referred to us, and we can help them find an ostomy nurse wherever they live. Because as we know, we get a lot of patients from different parts of the world, parts of Pennsylvania, parts of New Jersey, but there's ostomy nurses everywhere. They're just not advertised. We're a little hidden secret.
Yep.
But we're definitely here for patients.
Yeah, so I think it's important to recognize that your services and needs for these patients go on for the rest of their lives, and they may change as your body changes, as their body changes. And so the fact that you become their friend for life is wonderful, because they can come back to you years later and say, I now have a problem.
Yeah.
So I want to thank everybody for their little talks. I think everybody gave some really great information. I'm now inspired to go treat colorectal cancer. But we have questions. We're going to open it now to the audience for questions. Please feel free to drop a question in the chat function. And there's a moderator that's sending those questions to me, and then I'm going to push them out to the panelists. And if we don't get to your question this evening, because we only have about 20 minutes to do this, we will get back to you and answer at a later time. But I have a couple of questions that I'm going to start with, and I'm going to send the first question to Dr. Jane, and it's actually a combination of two questions. So the question was, I'm a 5-year colorectal cancer survivor. My last appointment was in November. I'm doing really well, but for future reference, what are the warning signs to be thinking about for cancer recurrence? And then secondly, and sort of tacking on to that, as a colorectal cancer survivor, what are some lifestyle changes that I can make now to decrease my risk of recurrence? Are there any precautions I need to take getting back into physical activity? And how much physical activity should I be aiming for? So we'll start with Dr. Jane.
So thanks for that question. It's a really good question. So for all the audience members, for the first 5 years after you finish treatment for colon and rectal cancers, you're followed pretty closely with periodic labs and CT scans. And after the 5-year mark, there's not a lot of evidence to do any more labs or CT scans, but you do still continue to need to get colonoscopies based on how your previous colonoscopies have been. So that would be largely directed by the gastroenterologist who is doing your screening colonoscopies after you finish treatment. In terms of the symptoms that you should be concerned about, obviously any blood in the stool should immediately trigger an evaluation. If you have kind of unexplained weight loss, loss of appetite, decreased energy, things like that should trigger a call to either your primary care doctor or your oncologist. Unexplained pain, etc. All of those things could possibly be a sign of recurrence, but not all symptoms are a sign of recurrence. So you also have to kind of look at sort of the course of things. If they're getting worse and there's no good explanation for them, then you should definitely, seek evaluation. In terms of reducing your risk, after the 5-year mark, your risk of recurrent colon cancer of that previous colon cancer is pretty low generally, but it can still come back. But your risk of other cancers are still there. So depending on your gender, you should definitely get age-appropriate screening. That could be mammograms, perhaps prostate cancer screening if it's warranted. Even lung cancer screening is available for some patients now. So you should definitely meet with your primary care provider, make sure you're up to date with your screening. And then from a lifestyle perspective, physical activity has consistently shown to be associated with reduced risk of recurrence of colon and rectal cancer. And it's also good for heart disease and diabetes and other things. So it's really a no-brainer to try and be physically active. In terms of the quantity of physical activity, most guidelines say trying to get 150 minutes a week of at least moderate intensity physical activity, along with 2 resistance training sessions, is sort of the accepted minimum that you should get. Obviously, more might be better, especially for weight loss and other things like that. But physical activity is key, and then some of those other things I mentioned earlier, limiting red meat, processed meat consumption, limiting alcohol, managing your weight, eating fiber, more plant-based foods. Those types of things are all also important and can increase the health of your colon and increase the biome profile in your colon and decrease inflammation and other things. So all of those things collectively can reduce your risk of colon cancer and other diseases as well.
Great. And Pam, as someone who is living with an ostomy and who may want to engage in physical activity, what do you typically recommend to your patients? What do you talk to them about when living with an ostomy and trying to get back into being more physically active?
There's specific pouches that you can use to feel a little bit more confident in moving around more. There's also specific belts that would protect your stoma. They're commercially available. There's also different ways, if it depends on what kind of stoma, that you can kind of regulate your output. We can talk about that.
So basically the message is having an ostomy doesn't mean you shouldn't be physically active and engaging in all those things you like to do, because there are ways to manage that.
Absolutely.
Cool.
And if they're not too sure, they can just call here and ask to talk to the ostomy nurse.
And Dr. Hall, as someone who's a genetically linked cancer survivor, are there any different things that patients should be worried about in terms of recurrence risk, or should be doing anything differently to be trying to minimize their risk of recurrence?
I think it's a good question, and I think it kind of gets at that question of, particularly young patients. I think the standard of care has become, certainly under 50 should get a genetic evaluation. They do have risks of having genes that may not only modulate the way they're going to screen for colon cancer over a lifetime, but also with some of these hereditary genes can come risks of other cancers. And for a woman, for instance, if they had one of the genes related to Lynch syndrome, that may mean thinking about ovarian or endometrial cancer risk, or with some of the other genes, there may be other cancer risks that go with those. So, I think that's really probably where the biggest value of the genetic evaluation is when someone's had cancer, because it's really sort of a part of survivorship moving forward, of identifying, I've kind of finished this phase, I've beat this cancer now. Now, what do I need to think about moving forward in terms of other risks in my life?
Great. So I'm going to ask you one more question, Mike. Someone asked, for the microsatellites unstable study, how long did the typical patient continue immunotherapy before getting to a state of remission?
Great question. I think there is still, it's still a little bit debated in the field, but I can say with pretty high confidence that many studies have been designed to have the maximum amount of time that you're on immunotherapy be 2 years. And I would say that when I've kind of done my own personal polling of my friends in the field and my colleagues, most are carrying immunotherapy out in responders to two years, and then generally stopping at that 2 years. And what some data have also looked at is that so for many people, that will be enough, and after 2 years, they will not recur. There will be no evidence that their disease will grow. Now, there will be a small number of people where you may see disease growth, and there have been some studies that have looked at reintroducing immunotherapy in that small group, and it looks like that can be done successfully. So I think that's actually a reasonable time mark, and that's what I've begun to practice in my own population.
Sounds good. So Dr. Pharma, I'm going to ask this question to you. It's actually two questions. One is a colonoscopy always 100% in detecting cancer? And then two, what do you see the role of colonoscopy in patients who are on maintenance chemotherapy, who may have stage 4 disease and are ongoing chemotherapy?
So colonoscopy is not 100%. As all of you know, and the reason why no one wants a colonoscopy is the bowel prep. For many of us who have been through that, I get it. But if depending on the prep, you may still, your colon may not be entirely clear, and you're looking in with a camera into the colon. So there may be areas that you don't see. There are some metrics that gastroenterologists and surgeons use when they're doing colonoscopies. For instance, how much time you're spending looking in the colon. If there was a small polyp, it potentially could be missed. So it's not 100%. And that's really looking at polyps. For a cancer, the chances of identifying a cancer in colonoscopy are much higher because it is a larger area, a larger lesion. And if you were having any symptoms like bleeding or anything, you're going in with the intent to specifically look for something like that. So it still is the gold standard. And so, your gastroenterologist, if they were concerned that maybe the prep wasn't well, they generally would tell you that and maybe schedule either a repeat short interval colonoscopy or a longer prep the next time you have a colonoscopy. Related to being on treatment, so we don't generally recommend screening colonoscopies on treatment. You're generally getting some other imaging, and colonoscopy is the best way to detect new colon cancers, but better than CAT scan or something like that. But you're generally, if you're on treatment, you're generally getting some scans that would identify a larger lesion. So you are being followed, and we're getting blood work and evaluating. So when you're on therapy, we don't generally recommend screening for another colon cancer. You're being managed for and being treated for a colon cancer. And in addition, if God forbid something came up, likely the chemotherapy you're on is going to be treating those types of cells anyway. So we don't generally recommend screening colonoscopies while on treatment. After treatment, and once we're kind of shift into the survivor or surveillance stage, then we do kind of circle back, as Dr. Jane said, for all these screening options for other cancers and also colon cancer. And your provider will discuss that with you at that time.
Great. So Dr. Hall and Dr. Jane, I'm going to ask this question to you. Dr. Hall first, what are the current screening guidelines that we should be sharing with our loved ones? And then to both Dr. Jane and Dr. Hall, what are we doing around the pandemic? Because with the pandemic, there's been sort of this question about whether preventive care should be pursued. And so because of the pandemic, should this be put on hold? And what are we doing really to work to prevent or to deal with this in the setting of the pandemic? So I'll start with Dr. Hall.
Sure. So outside of people who have a hereditary risk in the family, the current guideline would say for a colon cancer survivor, any first-degree relatives should be starting colonoscopies at age 40 and repeating colonoscopy every 5 years. Now that's aside from the hereditary risk. If there is, for instance, something like familial adenomatous polyposis or Lynch syndrome or one of these other genes in the family, then those often have a tighter interval for screening. But generally, I think the rule to remember is that if you have a first-degree relative with colon cancer, you should be starting early, which currently early is defined as age 40, and you should be repeating more frequently than the average person, and so that's currently defined as every 5 years. Now, there are some exceptions that occur within that. I think, if you have any question about whether your family may be higher risk, have that discussion with a gastroenterologist, but that's kind of the simplest rule. In terms of the pandemic, I think, there is, obviously everyone on the call has a lot of respect for the pandemic. We want to keep our patients and all of society safe from this virus. But I think the flip side of that is that these are still serious diseases. They still strike a lot of people. And as Dr. Pharma said really eloquently before, screening can make a huge difference, and early detection makes a huge difference in this disease. So I think that many centers now that we're 6 months into this pandemic have figured out ways and have technologies to screen people rapidly or relatively rapidly who are coming in from procedures. Now that we all suddenly worldwide realize that we need a whole heck of a lot more N95 masks and other things that we didn't think we needed so many of before, now they're kind of plentiful in cancer centers, and they're being used by the doctors who are using scopes and sometimes by patients if they're high risk. So I think the bottom line, without belaboring this, is I think we have learned a lot about getting ourselves back up to speed of performing even routine colonoscopies safely. So I would really encourage people to not put it off anymore, because I think, particularly at Fox Chase, we've been doing this since really about a month into this. We can offer people a safe colonoscopy with a really high degree of safety. And if people don't feel safe at the doc they were going to before, they're welcome to come here, because I think we can do this very safely for them and really keep them safe from colon cancer. And hopefully Dr. Jane has some other ideas too, but I think hopefully they'll say the same.
Yeah, Dr. Jane, your thoughts?
Yeah, I agree and completely support everything Dr. Hall was saying. In addition, we are testing all of our patients for COVID before any procedure, and we do screen all patients and visitors for high-risk travel, and we check everyone's temperature. And in general, we're not allowing visitors into Fox Chase. So Fox Chase is fortunate to not actually be taking care of any active COVID patients. So it's generally a very, very safe place for patients. Just to add to the screening question, Dr. Hall was focusing more on patients with higher risk. For an average risk patients, colonoscopy is still considered the gold standard, but there are other options. There's the stool occult blood test, which can be done annually. There's stool DNA tests that are around now. You might have heard of Cologuard. That's a company that does have approval for average risk screening for patients who choose not to undergo a colonoscopy. So, there are other ways to screen for this disease that might not be as good as a colonoscopy, but are still definitely better than doing nothing. So I think that's really important to be aware of for the average risk population.
All right, thank you. So This is the last question of the evening because it's getting close to 7:30. And this is for all the panelists. Dr. Meyer had to leave, but for everyone else, and I'll start with Dr. Pharma for this question. If we all go to bed tonight and wake up in 2025, what would you say is the biggest change in your specific area of expertise that you would see?
Number one, I can't wait to that because I want this year to be over. So I treat other cancers, and I really think, like I said before, I think when we can find, and I think as many of us had said, immunotherapy, or other therapies that can increase the response rates, that if you have metastatic disease or advanced disease, that we can see dramatic shrinkage of the tumors, or they go away, that would be amazing. Or that we can convert patients that we never thought could undergo surgery to being surgically resectable. That's what I would want. I think we've made really, really amazing strides, but there's still, if we can figure out the puzzle of immunotherapy and how to treat not 5 to 10% of patients, but 60% of patients, that will really, really make dramatic changes. So, and then increasing options for screening. Maybe we don't all need to have these colonoscopies that I just, promoted. Maybe there'll be something else that would be, much easier for everyone, that we can increase screening and detection. That would be great.
So Pam, how about you on the supportive care side? What would be something that 5 years from now you'd be super excited to see?
In my time here, we've actually seen patients recover so much quicker, like Dr. Pharma described about all of the minimally invasive or the less invasive surgeries. I would like to see that still escalate. Quick turnaround of the chemotherapy side effects, all of that. Just, come in, get done what you need to get done, and let's get going. And just have it just be a blip on your radar that you don't have to really worry about later on down the road. I would love to see it not be a chronic disease, but more of just something that you have to deal with and then you can move on. I know that sounds very simplistic, but
I think that's a great idea. And how about Dr. Jane, what would you think 5 years from now, if you woke up tomorrow, super excited about?
So I think the biggest advances in oncology in the last 5 years have definitely been the approval of many immunotherapy drugs in treating a variety of cancers. And unfortunately, the majority of colon cancer patients are still ineligible for immunotherapy because the drugs haven't been shown to be effective. I'm really hopeful that that changes by 2025, because even in patients with stage 4 disease, we are seeing that some patients can even be cured with immunotherapy. And that was essentially unheard of before these immunotherapy drugs were developed. So, if we can offer those long, durable responses with less toxicity with immunotherapy to all colon and rectal cancer patients, I think that would definitely be my dream for 2025.
All right, and Dr. Hall, you get the last word. What would you want to see in 2025 that you would be celebrating?
I think we've already seen some pretty amazing advances in molecular diagnostics just in the last few years in terms of the introduction of next generation sequencing. We went from a technology 5 years ago where we would plod along gene by gene to sequence the genome. Now we can literally sequence a whole person's genome in just a few hours. So our diagnostics are very powerful, and I think the way that we're already seeing hints that they could be applied is in being able to detect cancers at stages, at times that they're so early that we wouldn't even necessarily even see them yet, or know that they're there in the colon. We can use molecular diagnostics and next-gen sequencing through a blood test, really, to sometimes pick up the early signals of some of the earliest cancers that are starting to put DNA into our blood. The thing that we're still getting good at, but I think we're going to get good really fast, is at sorting out the target, what we want to find in the blood, the sign that there may be a malignant polyp in the colon or an early ovarian cancer, and sorting that out from all the noise of everything else that's going on in our body. But that's really actually just a computational problem. It's not really making our diagnostics necessarily any better. So I think we actually already have the smarts and the tools to do that. Now it's just being able to sort that out. And there were actually a couple posters and things presented at GI ASCO and at ASCO this year that are already kind of heading down that pathway. And so I think that is going to be very powerful technology that I think may be available to us by 2025. And I think people are going to want to take advantage of that because, you know, to be able to find and know early on that there may be something brewing that otherwise, you know, currently would take multiple CAT scans or colonoscopies or whatever to find, I think is actually incredibly powerful.
Well, thank you all. It's 7:34, so we're going to wrap up today's session. I want to thank each of the panelists for participating and sharing with us with the latest updates. I want to thank each and every one of you who tuned in tonight for sharing your evening with us. And really participating in and sending in some really great questions. And I also want to thank our exhibitors and the advocacy organizations for sponsoring tonight. And this was my first virtual event, so I'm super excited that you all came out for it. And I look forward to seeing you all at future events. There are other Together Facing events and other virtual events that Fox Chase is having. So please please stay tuned for those. And I look forward to seeing you at some additional events. And again, to all the panelists and to everybody who participated, thank you so much and have a great night.
Thanks, everyone.
Thank you. Bye.